Hello there, everyone. My name is Patrick Farrell. I am absolutely delighted to be here today for this session launching the Chief Medical Officer's Annual Report for 2023. As you can see on the slide behind me, we have a QR code, so please feel free to scan this while I finish off the introductions here and get reading. Very shortly, I'll pass over to Professor Sir Gregor Smith to launch this year's report formally. This presentation will be followed by another from Alison Leach. Alison is the Assistant Service Manager for the Edinburgh Link Worker Network, and she will talk to us about social prescribing in Scotland. And finally, to round off this session, we'll have a panel Q&A to explore the themes of the report in a little more detail. So without further delay, please welcome the Chief Medical Officer for Scotland, Professor Sir Gregor Smith.
Well, good morning, everyone. How are we? I heard some whoops from over here. I heard some, it's Monday from over here. Welcome to Glasgow. Many of you will know that Glasgow is my city. It's lovely to be starting the week in Glasgow instead of Edinburgh. And today we're launching my annual report. It's a really important report, this one for me. This is the year that we celebrate the 75th anniversary of the inception of the NHS in Scotland. That's a huge milestone. But it does feel like we're at a pivotal moment. And so when we started to put together the annual report this year, we had a number of things that we wanted to try to get across in this report. Now, before I start anything else, what I want to do is, there's a number of people I really want to thank. So the first person I want to thank, the most important, is actually Patrick. Patrick, our editor-in-chief, who's put together this report, who has spent a huge amount of time and effort in making sure that the contributions from a variety of different people fit together perfectly in the report as it is published this morning. So Patrick, congratulations on the report that you've produced. I'm proud of it, really, really proud of it. I also want to thank the number of contributors. There's actually too many to mention individually, but the number of contributors who've written different sections of the report this year. This is not a singular effort, this is a collective effort, and that's the important thing about the content that you're going to read in this report and that we're going to speak about over the course of this session. And the last person I want to thank, or the last people I want to thank, are my deputies. They're sitting there, I can see them in the second row back, or third row back. Graham, Marion and Nicola, all of whom have helped me with my thought processes as we've developed the themes of the report this year. And Nicola came up with the title, Doing the Right Thing. Doing the Right Thing feels like the right title for this year's report. It feels like at this moment in time we need to check in and make sure that actually the way that we provide care in the 75th anniversary of the year of the NHS is still the way that we want to. So, what's in the report this year? First thing I'd speak about in the report is this first chapter. This first chapter is one that I wrote myself. It's really, really important for me. Within this chapter, I begin to outline the 4 big population health challenges that I see we face in Scotland just now. First of those is the ongoing threat of infectious disease. That's not gone away. And we're not talking just about COVID-19 here, of course. We're talking about the re-emergence of other infectious disease that we've had to contend with over the course of the last winter, whether that be flu, Group A streptococcus, there'll be many others that we face as well. And alongside that, it emphasises the importance of maximising the protection we can achieve across our whole population from a wonderful vaccine programme. But we also need to make sure that we're countering the threat of antimicrobial resistance now and in the future, and unfortunately that we're preparing for what might be the next pandemic whenever that might come. Second population health challenge. Second population health challenge started pre-pandemic, but it's been accelerated by the impact of the pandemic and then more recently by the cost of living crisis. We've seen healthy life expectancy stalling and even reversing in many of our populations in Scotland. We've seen health inequalities widening. That's unacceptable. We need to address that urgently and as an emergency. Now, the third population health challenge. The third population health challenge is about how do we, in the 75th year of the NHS, how do we make sure that we have a sustainable health and care system? Not only able to provide the care to people that they need just now, but actually for us to prepare for the next 20 years as well. When you look at the wonderful Scottish Burden of Disease study that Public Health Scotland published in 2021, you start to see the stark statistics, the modelling, which shows 21% increase in the burden of disease across Scotland over this next 20 years. So we need to do things differently. And one of the ways that we can do that is to make sure that we're providing sustainable, high-value care. And if we're talking about sustainability, the fourth population health challenge is about actually how we achieve sustainable health care in the context of the climate emergency. What can health and care do to contribute and mitigate the impact of climate change on our population? Because that change and threat to health is an issue which we're starting to see impact even now. So this isn't some sort of philosophical, existential threat which might happen in the future. This is a threat which we face every day, even now, and we need to make sure that we take the right steps to reduce the impact of. 4 great population health challenges. But the final challenge that I've outlined in the first chapter, the final challenge is something which is existential and which we must realise is happening around about as we try to deliver care. Because in this moment of recovery that we have in the NHS in Scotland in its 75th year, there's a real threat to the way that we provide care. There's a real risk that we allow ourselves to become transactional technicians within a healthcare system that's industrialised, and that we lose the essence of why we came into the profession, to provide careful, considerate, kind care with empathy and compassion at its heart, where we use the biometric model of care in perfect balance with the biographical model of care, where we make sure that people's results and our clinical findings are taken together with people's stories and their preferences. That's the heart of evidence-based medicine, as Sackett described it. We need to go back to those core principles of careful and kind care. And in this opening chapter, I'll describe 6 principles that help that. So we call this opening chapter Being Human, and I think it's probably one of the most important chapters that we've written in the realistic medicine history, because this is a point in time where I think that we need to take stock of the direction that we're currently travelling. These principles, which are summarised here, are something that I would like to see the system adopt right across Scotland. These are things that are important, that can change the way that we experience how we provide care, but more importantly, for the people who are receiving care, that changes how they receive the care as well. And I believe that if we adopt these 6 principles across the country consistently, all of us who work within NHS and care across Scotland, our experience of how we deliver care, our experience of how we work on a day-to-day basis will be so much greater as a consequence of that as well. The next chapter starts to develop the thought of how do we provide sustainable care in the context of more intense clinical practice. And I believe that realistic medicine still holds the answer to that. I believe that realistic medicine has at its heart the 6 principles that allow us to achieve sustainable care. Because what they do is they begin to develop this concept of value-based health and care. And this chapter begins to outline what we mean by sustainable care in that context. Now, it's really important that people are supported to practice in that way. I'm delighted that organisations like NES have contributed so hugely to the training packages which begin to support that. And when I spoke to the board of NES recently, I had a huge commitment from their chief executive, Karen Reid, and from their chair, David Garbett, as to what NES could go and do further for us as well in providing people across Scotland to provide this type of care. And the tools that NES will provide, alongside the tools that we already have, such as the Atlas of Variation, allow us to have the conversations with the people we provide care to that looks at these different dimensions of value. Now, person-centred care still sits at the heart of this, because personalised value is perhaps the most important dimension of value. But we do also need to take into account population value and technical value and societal value when we're considering these conversations as well. And the tools that are being produced by NES begin to help us with that. The next chapter explores in more depth the issue of health inequalities in Scotland. And here, in this, you can see Marmot Man that sees the relative contributions of different aspects of public service which contribute to health. Now, you'll note that health and social care contributes 20% of that contribution to good health. But that 20% contribution is incredibly important. What can we do as clinicians within the system that helps broader population health? Well, we've got a really important role as advocates, as conveners of people who have influence across the system. The concept of anchor institutions is something I'm incredibly interested in. I think is as yet an untapped resource within the NHS in terms of how we can help to build stronger communities. And this is how we can maximise well-being across this population, alongside these other broad approaches in policy and in behavioural change that can start to improve health. And we explore the concept, particularly of the role of the well-being economy in Scotland and how we try to eradicate some of the fundamental causes of these inequalities that exist within our society. Now, to do that, for me, one of the most important things is that we leave no one behind, is that we reduce the level of marginalisation and alienation that exists within our population. Jimmy Reid, 50 years ago, spoke just 3 or 4 miles from here at Glasgow University about the alienation that existed across Scotland at that point in time, and there still exists to this day alienation that needs addressed. And one of the ways that we can do that is to use the trusted voices within the NHS, within these anchor institutions, to try and reach those people who so far we've been unable to do. The next substantial chapter is about our role in improving climate and health, the impact that it has on health and the impact that health and care has on the climate as well. Many of you will know this is a subject which is really important to me. And we've made good progress in Scotland since we launched our strategy on sustainability and climate action back in September. This is a public health emergency. Please make no bones about it. We're already seeing the impact of climate change on health, even in this country, never mind globally. The extreme weather we've experienced over the last year, most evident in the southern England, led to well over 2,000 excess deaths as a consequence of that. We're seeing spreading vector-borne disease in Scotland even to this point. And now Lyme disease is almost ubiquitous. The ticks that cause Lyme disease is almost ubiquitous across Scotland, whereas it used to be in fairly designated areas. This is the type of change that we need to prepare for. And health has a huge contribution to make in terms of reducing the impact. Scotland's one of over 60 countries now which has signed up after COP26 to a declaration to become a zero-emission health service by 2040. That's an ambitious target, but it's a necessary target that we can all play our part in. And I'm delighted, really genuinely delighted, to see such enthusiasm coming from people across Scotland to play their part. So much so that Scotland recently became the first country in Europe to stop the procurement of desflurane, a particularly harmful volatile anaesthetic gas, because there's alternatives available to us which are much kinder to the environment. And that's just one of countless examples. But there's also opportunity in here as well, in the way that we can promote greener, healthier pathways of care as well. The Green Health Partnerships across Scotland are doing wonderful work in making sure that greener forms of social prescribing. We're going to hear some more about some of that work today from Alison. So the work has already started to begin to reduce the impact. And we need to do this consistently and at scale across the country. And those co-benefits, more activity, greener prescribing, will also improve people's health as well. The final chapter relates to the health of our nation. And there are some stark data that are presented in this chapter. When you look at the inequality gap that exists here in life expectancy, for males it's 14 years, but in healthy life expectancy that increases to 26 years. 26 additional years of poorer health who people experience just because of the place that they were born. That's unacceptable, and that's something we need to make progress on urgently. And in the chart, it's on the screen here just now, in the red, you can start to see the contribution of deprivation on various diseases and the disability-adjusted life years that are lost every year as a result of that. Whether that be drug use, ischemic heart disease, whether that be COPD, whether that be lung cancer, you can see the significant impact that deprivation has on the health of our population, and we need to address that with urgency. So, in finishing, these are not distinct and separate challenges. This is the really key message I want to get across to you. Each one of these challenges is interlinked. Each one of these challenges rubs up against the other and influences the other. If we are not more respectful of our environment, if we don't balance our relationship with the environment, we will suffer greater ill health through greater infectious disease. It will be those who are already disadvantaged in society who suffer the most of that, and it will place greater pressure on our services as well. And you could describe the relationship in those terms across any of those four great population health challenges. But in meeting those challenges, we've got a real opportunity, huge opportunity, to revisit why we all came in to provide care as well. To make sure that we don't blindly go down a route where we're providing transactional care and we forget the privilege of sitting with someone at their most vulnerable who needs our help and is just looking for some empathy and compassion. And if I could give you one central message today, it's to make sure that between us collectively, in the 75th year of the NHS, is that we build back an NHS post-pandemic that has careful and kind care at its heart. Now, one of the people who is already doing that is a links worker who I'm delighted is going to speak to us today, Alison. Careful and kind care is at the heart of the links programme. Can I invite you to the lectern just now to say a little bit about some of the work you've been involved in?
So thank you very much for the invitation to take part today. It's a great opportunity to highlight the work that's happening across Scotland. As mentioned, I'm part of the Edinburgh Community Link Worker and have been for just over 6 years. I lead on the Scottish Social Prescribing Network, and I'm also part of the working group of the Scottish Community Link Worker Network. So what is social prescribing? The Scottish Social Prescribing Network was invited by the Global Social Prescribing Alliance to take part in a research study to find an internationally accepted definition of social prescribing, which is detailed here. This definition was agreed on by 48 experts from 26 different countries, which includes Scotland, and has recently been accepted by the British Medical Journal. The Global Social Prescribing Alliance is a group of worldwide partners who recognise that what keeps us well is more than medicine. The Alliance's vision is enabling thriving communities to deliver a social revolution for their health and well-being while generating value. Its mission is to establish a global working group dedicated to the advancement of social prescribing through promotion, collaboration and innovation. And the Alliance's work supports the implementation of the UN Sustainable Development Goal 3, which is good health and well-being. On Social Prescribing Day in March earlier this year, the Global Alliance launched the first worldwide report on social prescribing, which saw specific mentions of the Edinburgh and Glasgow link worker programme as part of the case study in Scotland within the report. So what does social prescribing look like in Scotland? There are currently around 300 link workers as part of the government-funded programme. These link workers are supported by the Scottish Community Link Worker Network, which was established in 2020 and is hosted by Voluntary Health Scotland and funded by Scottish Government. The Scottish Social Prescribing Network was also established in 2020 by volunteers and has recently received some funding from the Scottish Government to allow the network to grow, focusing on developing support and coordination of wider social prescribing strands, including sectors such as sport, culture, academia and research. The Scottish Social Prescribing Network has developed good working links with the National Academy of Social Prescribing in London and with colleagues within the Welsh Government who will be launching the results of their national consultation on social prescribing later this summer. Some basic mapping has taken place which shows that most health boards have some form of social prescribing running, while more in-depth work is needed on this. And while social prescribing is increasing in profile, we can see from here that some programmes have ended or are due to end, and while some programmes are under threat from funding uncertainty. So the Edinburgh Community Link Worker Service. Edinburgh programme is one of the 5 early adopter sites to be established following the 2016 Manifesto Pledge to introduce community link workers across Scotland. The other sites being Glasgow, Dundee, Inverclyde and North Ayrshire. We started out in 21 practices in areas of deprivation with the aim of tackling health inequalities and have grown to have a presence in 45 practices across the city as a result of increasing awareness of the positive impact a link worker can have in a practice. Our programme is quite unique in its setup in that our model was chosen to ensure that the link workers are firmly embedded in the areas that they work in and bring more collaborative working between primary care and the third sector. We ask that each practice appoints a GP lead to be the point of contact for their link worker to embed them into the practice team, and we ensure that the network is fully supported by 2 GP clinical advisors and a clinical psychologist to provide support to the link workers in their case review sessions. No formal reporting is required by a link worker programme, but we strive to continually monitor and evaluate the work that we do by producing stats and an annual report. Last year, the Edinburgh Health and Social Care Partnership invested into a pilot with Elemental, which is a social prescribing software system that talks directly to vision, which makes referrals more streamlined and opens up the potential for greater evaluation and research. Elemental is also being trialled in Highland and East Lothian link worker programmes, and Spring Social Prescribing also use this as their recording system. So these are some of the highlights from our link worker programme. We have a good working relationship with education at Bromley by Bow, which is often seen as where social prescribing began. We've had 3 lots of training from the team, and the most recent was offered out to all other link workers across the country, and the feedback has been very positive. We hope that this can be taken on by the Scottish Link Worker Network and that a formal introduction to Link Worker in Scotland training package could be established and available for any programme to use. The University of Manchester UK-wide research project is funded by the National Institute for Health and Care Research and will evaluate GP-based link workers across the UK. And now that sites have been selected, the next phase will begin and will last for approximately 2 years. The CMO's report touches on blue and green prescribing, and our programme has recently been involved in training with the RSPB, building on a pilot that took place in 5 practices across Edinburgh. This training was well received and aimed at encouraging patients to use their local green spaces to improve well-being, and it's hoped that this can be rolled out across the country. The link workers also reported on improving their own well-being and using the green space. We celebrated our 5-year anniversary in October last year, and we can see here some of the highlights of what we've achieved. The top 3 reasons for referral are consistent year on year, but it's important to note that the top onward referral destinations are not a mirror image of this. An example of this would be a GP referring a patient for low mood or mental health issues, and the link worker discovering that this is because the patient is socially isolated, and where the outcome is a link being made to an activity group rather than a mental health support group. Our link workers don't apply for benefits due to the complexity of these issues, but they can apply for small grants for furniture, white goods, or clothing. Last year, the amount applied for increased by over 300%, reflecting the challenges of the cost of living crisis. And they also report seeing an increase in referrals to food banks, clothing banks, fuel banks, and school uniform banks. The link workers, especially those in areas of deprivation, have seen a real shift in their roles in the past few years. They see an increase in helping patients with those needs at the bottom of Maslow's hierarchy of needs. If someone doesn't have a safe, warm home or can afford to eat, then anything else in life is going to be extremely challenging. Housing is probably the biggest issue that we face in Edinburgh, and we do work collaboratively with the City of Edinburgh Council housing representatives to try and understand each other's position a little better. There are currently 6,000 people classed as homeless in Edinburgh. And whilst those with gold priority, which is the top priority, have to wait an average of 300 days before a property becomes available. We're due to meet with the new Housing Minister shortly to highlight how housing can quickly become a medical issue, and in particular, to quote Professor Michael Marmot, what is the point of treating someone to send them back to the conditions that made them sick in the first place? We continually seek feedback from all stakeholders within our programme, and we have some thoughts here from GPs, which I'll just let you read. We've not had a GP hand back a link worker yet anyway. And we have a practice manager's thoughts here. This practice manager has been involved in the programme right from the start and the previous headroom project. And it just highlights bringing together the third sector organisations in the practice. This practice manager actually held a PLT in the local third sector organisation, which just really was successful and built up the bonds between the two. And some feedback from patients here. So no presentation about link working would be complete without a case study. Annie is a patient I worked with when I had a caseload. She had been seeing her GP for some months because of her poor mental health, which was suffering because of her housing situation. Her medication had been increased, but there was little else her GP could offer. Annie wrote about her experience for me, which I would like to share today. I am retired and returned to Edinburgh after a long absence. I privately rented for a few years, but this took a toll financially and resulted in rent arrears. I applied for social housing, but my situation wasn't bad enough to give me anything like the points that were needed for my bids to even be considered, and I faced being offered a B&B for a couple of years. I felt trapped, hopeless and helpless. The stress made my mental health worse, and I was seeing my GP regularly as a result. One day I saw a different doctor at my surgery, and they suggested I see their link worker. An appointment was made for us to meet within 2 weeks of the GP referring me. The link worker told me she had allocated an hour for our first appointment. I breathed a huge sigh of relief, and I knew that I was in the right place in front of someone who might just be able to help. The link worker listened well and asked all the right questions, and then came suggestions plus actions to back these up. I could apply to housing associations, which I didn't know about. She also got me a small grant within a week, which was a godsend. The link worker continued to work on my behalf and give me progress reports. We met up regularly in one of the places that she works. The ongoing support and her efforts on my behalf gave me a sense of hope. My mood began to improve because I had her as an active ally. Sometime later, the Housing Association rang to say that I was shortlisted for the flat. I was second on the list, but it was looking unlikely that the first people would take it. 2 weeks later, I was told the first people had taken it. My heart plummeted. I was back to square one, but at least I still had my link worker. With her help, I began to move forward again, and then a call came to say that the flat was mine after all. The link worker was again on hand to get me a charitable grant to help me clear rent arrears. She also helped me apply to the Scottish Welfare Fund for furniture. I'm so glad that my GP introduced us. Everyone who is in difficulty should have a community link worker, or as I prefer to call mine, a light worker. My life changed for the better the moment I met mine. I'd like to think that Annie's experience links to Chapter 1 of the CMO's report, where it states that care is human. It is about personal interaction, uncertainty, co-creation, and compassion in managing risk, anxiety, and hope. It's about the power of our relationships and being able to jointly identify issues that affect us, our preferences, and our goals. And I think this embodies the role of a link worker perfectly. And just to finish, one of the biggest challenges we face is hearing, "Show me the evidence that link working works." I absolutely know that link working works, and I hope that I've been able to show just some of the ways that we can make a difference today. Thank you.